Okay, let's get started. Welcome to part 2 on renal infection versus infarction. And we left off last time mentioning unusual infections, or beginning to think about what is there beyond the usual acute pyelonephritis due to E. coli. What else do we need to be thinking about? Well, one of the classic things is XGP, Xanthogranulomatous pyelonephritis. The typical description is an enlarged kidney with lack of function, with a dense central calcification in the pelvis. And in this case, you see a normally functioning left kidney, markedly dilated calyces right kidney, large stones centrally, and thinning of the cortices bilaterally. Here it is on the coronal view as well. There's a little bit of functioning cortex, but very minimal. These patients invariably end up with nephrectomies. Some facts: it's a chronic destructive granulomatous process. It results from a typical incomplete immune response to subacute bacterial infection. We tend to say, oh, it must be diabetic patients, but less than 10% are diabetic. The infection that you see a high percent of diabetes is emphysematous pyelonephritis, not XGP. It's more common in women than men. It's more common in middle age, and classic presentations: pyuria, positive cultures, and hematuria in a bit under 20% of cases. As I mentioned, the large staghorn calculus with a contracted pelvis is the classic finding, though I have seen cases of XGP that are really difficult to diagnose, where there's no stone present and it looks like something infiltrating the kidney, and you could be confused perhaps with TCC or occasionally even with lymphoma. The kidney is enlarged. It's rare to get bilateral XGP. It's usually a unilateral process. I think I've seen one case with a late-stage XGP on one side and very early disease on the other side. And one of the things about XGP, like many renal infections, but this is more impressive, it can extend beyond the kidney and the perirenal space and involve the psoas or even the paraspinal muscles. Another case: large central calculi, not just one, there's multiple. The kidney's enlarged compared left to right, and there's no functioning kidney left basically on the right side. If you look at the left side, there is some high density, something's going on in the pelvis, and there's a stone present. This is the case where it almost looks like bilateral XGP. When you give contrast on the right side, you can see there's a little bit of function left in the lower pole of the kidney. There's better function on the left kidney, but again, look how thick the pelvis is and that stone. If that's not treated aggressively, the patient will not only lose most of the function of the right kidney, which they've lost already, but they're going to lose a lot of the function of the left kidney. So this is really going to need some expert surgical involvement in a case like this. Now, way back when, we wrote an article about XGP. This was the first article. And interestingly, before CT, the way XGP would present would be back pain. The surgeon would operate. They would find the paraspinal abscess, and they follow it into the kidney. And so when we first started off, the cases we saw were aggressive: peri and pararenal space involvement, psoas muscle involvement. Nearly half the patients had psoas muscle involvement. Now you're hardly ever going to see that. Here's an example: non-functioning right kidney, a large kidney, the dilated calyces, inflammation, and here's the psoas involvement extending through to involve the paraspinal muscles as well. This patient will need surgery and drainage and a right nephrectomy. Here's a case where you look and you say, could this be lymphoma? Could this be a TCC? Something is really infiltrating the patient's right kidney. But interestingly, I don't see a stone. This ended up also getting a nephrectomy, and this was XGP. It was felt to be a renal cell carcinoma because the calyces are distorted. It looked like an infiltrating process. There was some stranding in nodes present. What you really were looking at were markedly dilated calyces due to a central stricture. What made this case hard to diagnose was the lack of a large staghorn calculus. If you would have put a stone, let's say right here by the pelvis, then it would have been an easy call of XGP. In this case, it was not, and this was a great example of XGP being confused with a renal tumor, which was felt to represent a TCC, but was XGP. Now, seeing other infections, what else can we think about? Here's a patient with hematuria. Unlike the last case, this is a small kidney, ring-like calcifications, really extensive calcifications present. Now, what can give you calcifications? We know you can get it in tumor, XGP, scarring, but also infection. Well, what infection really gives you a small kidney with extensive calcification, and when you give contrast, you may see no function or minimal function, and that's going to be tuberculosis. This was a great case. Atrophic left kidney, dense calcifications, minimal function. There really is no para-aortic adenopathy, but this was TB. Now, we don't see TB very commonly. When we do, we see it with strictures of the ureter. Now, TB is a very common disease. Let me be clear. Baltimore is one of the key places that has TB, but it's typically pulmonary. The number of cases of renal TB I've seen are indeed very small. Renal TB almost always occurs owing to infection by Mycobacterium tuberculosis. Secondary TB owing to reactivation of latent infection after initial dissemination to diverse organs is very common. It's interesting, the GU tract is one of the common extrapulmonary sites of TB, accounting for about 20% of cases, more commonly in relatively younger adults. As I mentioned, I know about TB. I've seen some nice cases in the bowel. I've seen lots of pulmonary cases. We see cases involving the liver and the spleen, but the number of cases I see involving the kidney is really small. Now, perhaps the patients simply come in with routine infection and we never get really good follow-up, but the number of cases in my teaching file of TB is indeed very small, and these days I hardly ever see it. Looking at more severe infection, one of the classics is emphysematous pyelonephritis. This is a life-threatening infection of the kidneys characterized by gas formation within or around the kidney or both. Unlike XGP, where less than 10% of diabetics, here the majority of patients, over 90% of diabetic patients, and they're typically poorly or not controlled diabetics. We commonly see these in patients who are in nursing homes where patients have poor medical care. You can see this with immunosuppressed patients, but it's really, the way I would describe it, it's patients who are not getting really good medical care. Infections, E. coli, Klebsiella, Proteus are some of the things we typically would see. CT is a study of choice. It can show destruction of the parenchyma or edema of the parenchyma. You can see small amounts of air, maybe just a streak, or very extensive air. You may see fluid collections in or around the kidney. Air fluid levels occur, and it's aggressive, it's tissue necrosis. It's rare to get bilateral emphysematous pyelonephritis. Usually it's unilateral, but I've seen a couple cases of emphysematous pyelonephritis as well as emphysematous cystitis in the same patient. Here's a nice example. You look at the left kidney, lots of air in the kidney. There's a little bit of function. The way you describe the left kidney is a destructive process, and this is a surgical emergency. And here's another example. Basically, there is no functioning left kidney remaining. What we're looking at is a destroyed kidney, lots of air where the parenchyma was, the rest of the kidney is enlarged, and lots of inflammation in the entire area in question. Now, here's an example of a little bit less dramatic. You see a little bit of air here. No, the patient is not at instrumentation. If they had a stent or some procedure, you can see a little bit of air in the kidneys. This is not going to be the case here. You can see the right kidney is poorly functioning compared to the left kidney. You can see the renal pelvis is noted to be dilated. You could see stranding around the kidney. So surely this is infection, but what's really impressive is the infection really relates to the air. That's the number one finding to me, and this is emphysematous pyelonephritis, a really nice example. Now, other things we do look at are infarction. Now, renal infarcts are not that uncommon, particularly in a big city hospital. Patients with IV drug abuse are things you think about. You can see renal infarct for many reasons. Thromboembolism is one of the classic things. You see thrombus in the left side of the heart or in the aorta. You can get it from aneurysms of the aorta, which can release some plaque. Patients with bad atherosclerotic disease, patients with bacterial endocarditis, patients post transcatheter embolization or other endovascular procedures, patients who have dissection of the aorta and renal arteries are all possibilities. When you think about possibilities, we also think about vasculitis, polyarteritis nodosa, drug-induced vasculitis are all things that occur. We think about, I mentioned trauma, avulsion of the renal artery, penetrating vascular injuries, occlusion, paraneoplastic syndromes, hypercoagulability states, and acute venous occlusion. Now, the thing about infarcts, it can be challenging distinguishing infarcts from infection because infarcts can be segmental or global. They can be unilateral or both kidneys. They can be an isolated process or part of a multisystemic disease involvement. Acute and chronic renal infarction can occur in the same patient, and symptoms can range from acute flank pain to fever, like an FUO, to hematuria. Now, what do we look at from a CT perspective? We look at focal versus global involvement. Usually due to arterial inclusion, those are the patients with sudden flank pain. Again, depending on the etiology, unilateral, bilateral. You can have a cortical rim sign when the entire kidney is infarcted. I'll show you some examples of that. And if you don't make the diagnosis early, chronic renal infarction can appear as a small, poorly or non-functioning kidney. Some examples here. In this case, you see lack of enhancement of the left kidney, and then you see there's occlusion of the patient's left renal artery. There's an embolism with infarction of the left kidney, global infarct. Here's that same case again. So you want to look very carefully at the renal arteries. You'll want to look very carefully at the renal veins, but very nice example of a global infarct of the patient's left kidney. And again, if you get delayed scans, you might see a little bit of an enhancement around the edge, very minimal, but for the most part, there's a lack of enhancement of the entire kidney, and this is a large infarct. Here it is very nicely showing you that on the cinematic rendering. Now, one of the things I find helpful with 3D and renal infarct, or kidney in general, is being able to look at the renal arteries carefully, being able to look at the renal veins. So in this case, you saw the occlusion of the left renal artery just beyond its origin, and then you see the really large, almost global infarct of the left kidney. Let's do this. Let's look at one more case, and then let's take a break. Okay, here's an infarcted left kidney. Looks very much like the last case. And then when you looked carefully, you saw multiple pulmonary emboli. This patient had an infarcted left kidney and a PFO. Now, I mentioned about 3D imaging. Here's a patient with poorly functioning right kidney, areas of infarction. When you start looking carefully, you see the vessels. There's multiple small emboli. So there are multiple infarcts in the kidney of varying degrees of enhancement, or should I say lack of enhancement. A really nice example of multiple focal infarcts due to vascular involvement. And this was a patient who had atrial fibrillation, and that was the cause for the embolic phenomena and the renal infarcts. Here's another example. Again, very similar. In this case, it's bilateral, infarcts in both kidneys. For the most part, almost half the kidney on the left, a lot smaller involvement on the right. When you do have embolic phenomena like from endocarditis, anything cardiac related, it's very common to see bilateral involvement. Of course, one kidney will more typically be more extensively involved than the other. Now, it's important to look at the vessels carefully, and let's talk about that as we break for a few minutes. See you then. If you like this video, make sure to subscribe to the CTisus YouTube channel. You can also visit us at ctisus.com for even more videos, plus quizzes, pearls, protocols, and oh so much more. We're also in the App Store and have well over a dozen apps for iPhone and iPad, all completely free. Thanks for watching.